Clarifications? Dr. Tanya Swam.
Chairman, I thank Dr. Janil for the detailed replies. I have some clarifications. Regarding wellness and beauty salons claiming to offer treatments for slimming and detox, such as fat loss pills, lymphatic treatments to reduce cancer risk. 1, are these medical treatments? 2, how do we recognize misleading claims? And 3, who may the public lodge a complaint with?
Sir, I thank Dr. Tan for her questions. Certainly, if the claim is to treat an identifiable medical disease like cancer, that would be a misleading claim. And if they're an unlicensed provider, we can take them to task. I'd encourage the member or members of the public to notify us directly if they come across such an instance and make a complaint. And ultimately, perhaps one of the best ways to protect themselves is to have a regular relationship with a trusted care provider. I beg your pardon, was there a third question?
Something along the line. So 3 things. Are these considered medical treatments? 2, how do we recognize misleading claims? And 3, who do we report to?
Dr. Tan's second question of how to recognize a misleading claim. I think this is an area where there's quite a lot of education that's needed, and it's going to have to require ongoing efforts around public education because medical treatment does change. I think the key issue is that if the provider is licensed, they are required only to assert claims that are provable and demonstrable. And so I think the first thing is then to establish whether or not this is a licensed medical provider.
Ms. Ng Ling Ling.
Thank you, Chairman. I have 2 clarifications for Minister Ong. The first one is on the good news of normalizing telehealth, and I'm very glad to hear the response to my cut that the time-limited extension of telehealth for CHAS subsidies and MediSave to be applicable for chronic disease management is going to come. But in the time extension, it was specified for video consultation. So my clarification is for proven health tech, such as a class of remote vital sign monitoring technology that's proven effective for hypertension management, for example, in US as well as in pilots in Singapore, would they be considered? The second question I have is on the AAC. I can't agree with Minister Moore that community notes like this are extremely important to motivate our seniors, especially to live actively and maintain their health. I want to ask how fast will the expansion plan be? Because I have 2 sites in my constituency that has no AAC, and we have willing partners that are very keen to start. So I'd like to know a sense of the pace of expansion. Thanks.
On telehealth, the short answer is so long as appropriate, efficacious, we'd like to extend the support. You mentioned remote vital signs monitoring. These are actually these are free. If you have the remote apparatus, you can monitor without charges. But if you involve consultation, whether by phone, by video, these are efficacious intervention and they should be covered. What we want to is to bring telehealth to normalize the funding and support, but there's a range of practices, like Dr. Tanya Swan also mentioned, there's so many different kinds, and some will claim to be efficacious, but they are not. So I think we also need a gateway system to make sure that the legitimate ones, useful ones, we support, but keeping out the not useful or even detrimental ones. Expansion of AAC, we are on the same page. We want to expand as quickly as we can. I mentioned and I alluded to the possibility that this may become a significant national program. So give us some time. I'm in a hurry. As I mentioned to you, we are racing against time. The pace of aging is fast. In a community, we can see in months how some of our residents become frail. And they do need the support near their homes, in the neighborhoods, keep them active, healthy, give them friends. So I hope I can give an update very soon.
So Gerald Giam.
Sir, just now the second minister said that the home caregiving grant already extends to households earning the median income. According to the AIC website, the household monthly income per person ceiling for the HCG is $2,800. but according to the Department of Statistics, the median monthly household income from work per household member in 2022 was 3,287. So shouldn't the ACG be using the 3,287 number instead of 2,800? In any case, can the ACG qualifying income be pegged to the median income? Thank you.
Thank you to the member for that clarification question. It is pegged to the median income based on DOS statistics, but does not include the CPF by the employer. It doesn't include the CPF by the employer.
Ms. Carrie Tan.
Hi, I'd like to ask the Minister, since we have recognition that the aging is going at a relentless pace, and I'm just quite taken aback by the numbers of how many healthcare workers we need. Last year, I spoke about incorporating, or rather setting up a care force as part of national service so that our young men and women can be tapped on to help with the healthcare manpower needs. So is there any possibility that the ministry might look into this as a model that could help us with this very urgent care avalanche that simply just needs more hands on deck? Because I understand there are many functions within the healthcare system that do not require medical training and can relieve a lot of the nurses' workload. Thank you.
I'm sorry, I do not recall the Care Force proposal, but if it's meant to be some form of national service for women, I think need to post this to the Ministry of Defense. But I would say for MOH, if we really expand AACs into a ubiquitous support system for our aged and seniors, and to be able to befriend them, engage them in activities, teach them digital literacy, teach them how to use Health Hub, how to use Health 365, monitor their vital signs. I think we need a lot of volunteers and just befriending. In my own constituency, we are trying very hard to recruit such a care force. And you don't require a lot of medical training. In fact, you require a lot of heart and be able to commit a morning every month, during the weekend or every week is better, and just have enough hands and legs, and I think we can do a lot more for our seniors in the community.
Dr. Shahira Abdullah.
Thank you, SMS Dr. Janil, for your clarification. I just have two questions. So previously in KTPH, the dental clinic already offers the full range of subsidized specialized treatment, actually for many, many years. But now for the treatment to be subsidized, the hospital needs to partner with an NNC. So actually they do have the capacity and capability. So may I find out why this is so and how MOH decides which dental specialty to subsidize? Since now in the hospital, some are and some are not. So secondly, I'm heartened that there are institutional scholarships for special care and geriatric dentistry for students, but their career progression is still unclear, especially if the specialty is not recognized. So for example, if you want to go from a registrar to AC, you can't because there's no board exam to pass. So I understand that MOH will be doing a review, but for the time being, will MOH consider coming out with a set career progression ladder for them, especially in hospitals, because I think it will really encourage people to go into this field. Thank you.
So I thank Dr. Shahira for the questions. We will look at the career progression issue, but we also do need to make sure that where there is this process of specialist accreditation and career progression, we do give a structure that provides assurance to the practitioner as they progress along their career, the institution that employs him or her, and the patients. So I think we do want to wait for that process to work through as we review the needs and the process of doing specialist accreditation within dentistry. For the issue of subsidized treatments, the bottom line is that there are very few patients that require that type of treatment outside of the NSCs. The NSCs continue to have quite a lot of capacity, and we would like for these treatments to be provided where there is a significant patient load and significant service provider experience as well. So currently they're concentrated at the national centers.
Mr. Lewis Hung.
Thank
Thank you, sir. I thank SPS for sharing about the efforts we are making in terms of helping with the nurses' workload, including removing some of the administrative work. But could I just ask what else are we doing further? Because my worry is I know we are ramping up the hiring of more nurses, but that could be just replacing the nurses who are resigning, and we're in this vicious cycle. And if all the dialogues with nurses, there is this recurring cry for help and fatigue. So it's really not like a two-day vacation to rest and recharge, but really they're burning out. And I fear that we will lose more instead of able to hire more. And again, it's the vicious cycle that we're in now.
It's an important subject. I would say, particularly MPs such as you who come into contact with healthcare workers, you hear a lot more feedback that's more stark. And I think the pandemic has something to do with it. These 3 years, really the workload has been relentless. And so we know what they've been through, we have to support them fully. In terms of attrition, I should correct some misperception that we are losing doctors, we are losing local nurses. Actually, the attrition of doctors, local nurses has been stable throughout the pandemic, despite the very hard, very heavy workload. What we have lost is foreign nurses. I think was 7, 8, or 9%, which was at steady state. It jumped to 14% during the pandemic. And that's because many countries were desperate for nurses, and we lost foreign nurses because of that. So hospitals, certain wards, emergency departments, sometimes short-handed, answer is yes. And as I mentioned, this is the main issue. If we can set rest days, enforce rest time and all that, but we know our nurses, when they are patients, they will take care, even though it's their rest time. And I think the best way to support them, beef back up the manpower. We are not just replacing, we are planning to expand. As I mentioned just now, 49,000, we want to increase actually to 69,000 by 2030. And if you plot and interpolate the numbers in between, we do need to expand the manpower. And the work has started. The work has started. Both in terms of local recruitment, SPS Rahayu mentioned a lot of things we are doing. I should say, healthcare is an attractive sector for many young people. The number of new students cohort, every cohort, 1 in 20 chose healthcare. Majority are nurses, great majority nurses. So it's not a sector where people are avoiding. People want to join. I can't wish for more. You look at 20 students, I know 1 is joining MOH and our healthcare system. And if we keep our intake and the cohort sizes start to shrink, it's starting to shrink, it may well go up beyond 1 in 20. So we are getting our fair share, but we need to beef up to replace and expand our foreign nursing workforce. It is a competitive market out there. I don't want to describe in too much details what are the techniques that we're using, but I think Singapore is a fairly attractive place to many nurses out there. Similarly, as it is attractive to many of our young students, they want to join healthcare. And I think what is the attraction is we are a safe city to live in, and joining our system, there is a career. There is a pathway, and there is very good training. And by and large, except for the very small minority, it is a well-respected profession.
Dr. Lim Wee Kiak.
Thank you. So I'd like to thank the Minister for the 3,000 health points for those who first signed up for Healthier SG. I'd like to ask, like, for the elderly, especially those who do not have Healthy 365 and do not know how to encash these 3,000 health points, is there an option for them to ask for vouchers directly instead or something like that? Then the second part is that, will there be any other incentive schemes to retain people who have signed up for Healthier SG? So if they are compliant to whatever social prescription that's given by the GP, then what is the reward system going to be given to them? Then the last SQ is on Healthy 365 apps. You know, currently now, how many Singaporeans are actually on these particular apps now? Then it seems that you're going to push your main platform for Healthier SG through Health Hub as well as Healthy 365. You know, then what are the plans now to beef up to get Singaporeans to sign up on Healthy 365 apps?
I think there is an option to give vouchers. I will confirm. I believe there is. Second is the reward system after the sign-up. Because when it comes to preventive care, you cannot run away from exercise and taking steps, keeping your heartbeat moderate to intense certain times of the week, and therefore Health 365 is one way to keep you going. Yeah. Keep on reminding you that you can accumulate health points by having an active lifestyle. So this is the reward system that is long-lasting. Yeah. How to get more people on the Health 365? I think your neighbor has a very good suggestion, hold carnivals. Yeah. I think that is one way to get it kick-started, because we do know you hold a carnival, people do come down, participate, and have ambassadors. We will mobilize all our SG ambassadors, yeah? And they were very useful when we roll out Pioneer Generation, Merdeka Generation packages. Now we can use them and leverage their network to help people sign up for Healthier SG and also sign up for Health 365. You mentioned the two apps. One is Health Hub, one is Health 365. I just want to explain that we need both apps. I know there was a suggestion to lump everything into one app, but I think we have so many apps in our smartphone, we can live with two. There's a good reason. Health Hub is your private data. Your medical data, summary health data is in there, and you should access it using SingPass and have sufficiently high security. But it will also be shared. When health information bill, if it's passed by this House, these are data that can be shared across healthcare providers and different settings. And then Health 365 is your own lifestyle data. It should be just for yourself. You can show your doctor, but this is actually your data. It will not be shared.
Sipon Wing.
Chairman, I have two clarifications. As part of our plans to improve palliative and end-of-life care, how will the government promote the use and awareness of the My Legacy portal? As there's a lot of useful information and services inside, such as applying for your lasting power of attorney, as well as advanced care planning. I can say that many residents on the ground don't know about this, and I think it's useful for them to get more awareness about this. Second is that just now Minister mentioned that a lot of volunteers are needed for the AACs. Will MOH consider creating micro jobs for seniors to take up some of these tasks, like befriending other seniors, escort services for medical appointments? This will also keep them active and healthy in the spirit of Healthier SG. Thank you.
Thank you for reminding us on the My Legacy portal. It will be a very useful resource. But I think on the issue as personal as how you decide you want to go and where you want to go, I think it goes beyond a portal, that we need to actually consciously speak to patients and their loved ones and have that conversation early. And you never know, with Healthier SG, once you develop a long-term relationship, patient-doctor relationship with a trusted doctor, at some point it is something that a doctor can speak to you. And once you think about it, these are things you may have to even discuss within the family. And in that context, then refer to My Legacy portal. This is how I think it will work. It's quite unlike you surfing the internet, check ChatGPT, how should I go, and suddenly come out with a revelation. It's quite unlikely. It requires quite a serious, intimate discussion with somebody you trust. Second, will MOH consider micro jobs? I think we will. I'm keen to look into that. Many of our AACs actually looked into that. They do have one word of caution, that you don't want to pay your volunteers just cash. In fact, for many seniors, it's not about the payment, but about getting involved, feeling useful, and then being recognized in some way. It doesn't need to be paid. It could be health points or it could be something else. So I think we will think along those lines, but these are important suggestions.
Sir, I thank SMS Janil for the updates on the mental health and well-being efforts. I have a question on the training framework he mentioned earlier. Can I get clarifications on whether there is a regulatory body to manage the trained personnel that he mentioned earlier? And I ask because I understand that there will be peer leaders that will be involved, and I know that being peer leaders on the ground, there will be many. And I think there is a need for us to recognize that we want to keep this standards high, especially when it comes to mental health issues, although it's the early stages. So we need to ensure accountability, especially if things go wrong, and we need it to be carried out properly. Thank you.
So Dr. Wan Rizal raises a very good point, and it is precisely because the service provision in this space involves professionals from different sectors that have different processes of licensing and accreditation that answer to different professional bodies, that we do need to have a common language about how referrals are made, how care is coordinated, and how they are trained on a common framework to serve the same clients and patients. So the process is to bring the professional bodies together through the representatives that are participating in this approach to develop the national mental health competency framework, and through that have the same language and then the same high standards applied across all the different professional bodies, rather than try to, at this point in time, create a single regulatory framework for these sets of conditions. Thank you.
Mr. Jerugam.
Clarification. I'm not sure the Minister addressed my question about creating more temporary nursing home places for respite care. This is something that quite a few of my residents have requested for. Thank you.
Currently, there are 60 nursing homes already providing the temporary respite care. Of course, we want to do more. We have to expand the capabilities as well as capacities. And where they're available, we will make it available, and we're working with AIC to do so.
Dr. Tan Wu Meng, would you like to withdraw your amendment, please?
Mr. Chairman, if I may beg your indulgence through you, may I say a big thank you to our multi-ministry task force, ministers, senior ministers of state, senior parliamentary secretary. A very big thank you to our frontliners, healthcare workers, public officers. Your strength and effort got us through the pandemic and to a new normal, a new dawn, colored in DORSCON green. In Mandarin, 万分感谢我们的前线人员、医护人员、公务人员，有了你们的贡献、你们的牺牲，我们才有今天重新开放、雨过天晴。In Malay, sebagai satu community yang bergotong royong, sebagai satu community yang bersatu padu, sebagai kawan-kawan dari berbilang bangsa, bahasa dan agama, kami dapat mengatasi pandemik COVID-19.
Demo, please.
Forward together, healthier together, Majulah Singapura, Singapore forever. Mr. Chairman, I beg leave to withdraw my amendment.
Dr. Tan, when you asked for my indulgence, I didn't realize you're going to all the different languages. Lesson learned. Is the honourable member given leave to withdraw the amendment? I think leave of the majority is given, the amendment is withdrawn. The question is that a sum of 2,550,000,000, sorry, wrong ministry. The question is that a sum of $15,511,404,200 for head O stand part of the main estimates. As many as are of that opinion say aye. To the contrary say no. I think the ayes have it. The ayes have it. The question is that a sum of $1,377,740,000 for head O stand part of the development estimates. As many as are of that opinion say aye. To the contrary say no. I think the ayes have it. The ayes have it.